Hello, this is Dr. Eric Bricker, and thank you for watching AHealthcareZ. Today's topic is CVS to change PBM and pharmacy pricing. Now, today's information comes from a gentleman by the name of Adam Fein, who's a fantastic writer on drugchannels.net. He was actually quoted in the original Wall Street Journal article that wrote up this CVS price change. So I think it's important for us to sort of translate what he said and put it into actual numbers, right? So as you can imagine, with pharmacy pricing, it's complicated and it involves a ton of pricing. So we're going to go through that today. Now, the CVS price changes have two names. They're called CostVantage and TrueCost. And what they do is they take the acquisition cost, which is what it costs the pharmacy to get the medication itself, whether it be the Lipitor, the metformin, you name it, what have you, from the wholesaler. And let's say we have three different pharmacies, Pharmacy A, Pharmacy B, and Pharmacy C. And so the different pharmacies have different acquisition costs. So Pharmacy A can get the drug for $8, let's say for a 30-day supply. Pharmacy B can get it for $10, and Pharmacy C can get it for $12. Now, the MAC, the maximum allowable cost, is what the PBM then pays the pharmacy for the medication. So in the old world, in sort of the sort of mysterious pricing of PBMs and pharmacies, this is how it works today. So the maximum allowable cost can be all over the place, and it's negotiated between the pharmacy and the PBM. So what the PBM pays the pharmacy at Pharmacy A might be $40, at Pharmacy B it might be $8, and at Pharmacy C it might be $23, right? So it's all over the map. Now, the PBM then goes back and it charges the plan a different amount than the MAC, right? So let's just keep it easy because there's so many numbers up here. Let's just say that the PBM charges the plan the same amount regardless of which pharmacy they fill it at. So it charges the plan $50, $50, $50, and $50. Now, let's say the person's got a PPO plan designed, so they got a copay for this medication. So let's say it's a $30 copay, so the patient's going to be paying $30, $30, and $30. Now, the employer is going to pay the difference between what the plan needs to pay in total minus what the actual copay amount was. So the plan itself pays $20, $20, and $20. So here's where it gets interesting. In the sort of the confusing world of today of PBM and pharmacy pricing, then the pharmacy spread, in other words, what the pharmacy makes is the difference between the MAC minus the acquisition cost. So in this case, the pharmacy made $40 minus $8, they made $32. Pharmacy B, look at this. They only made $8, it cost them $10. The pharmacy lost $2 to fill this prescription. And this is what a lot of pharmacies, especially independent pharmacies, complain of. So Pharmacy A, let's just call that CVS. Just be like, look, they're being, the Caremark PBM is being super generous to the CVS pharmacy. And so the pharmacy is getting a super high MAC. It's getting $40 instead of $8. And as a result, the pharmacy spread is $32 at CVS, and it's negative $2 at the independent pharmacy. And then Pharmacy C could, let's say it's like a grocery store chain pharmacy, like Kroger. Okay, so there, the pharmacy spread is going to be $11. It's going to be the 23 minus the 12, and then the PBM spread is going to be $27. The 50 minus the 23. So what you have here is for medications that cost a total of, let's just say if you filled one prescription at each of these pharmacies, it would cost you $20, right? 8 plus 10 plus 12 is $20. Now, all of the markup for the pharmacy and the PBM combined, if you add up the 32 plus the negative 2 plus the 11 plus the 10 plus the 42 plus the 2 plus the 27, if you add all that up together, it comes up to $120 that goes to the middleman of the pharmacy and the PBM for medications that only cost $20. Now, that's the old world. Now let's go to the new world that was just announced. Let's go to the CostVantage world, where now, instead of the MAC being this independently negotiated amount that's really separate from the acquisition cost, now there is going to be a dispensing fee, regardless of that, it's just going to be added to the acquisition cost. And that dispensing fee, now this is important, that dispensing fee is not standard across all pharmacies. So CVS is going to negotiate a different dispensing fee at each pharmacy chain. So let's say they have a $12 dispensing fee at their own pharmacy, CVS, and they only have a $4 dispensing fee at the independent pharmacy, and let's say a $4 dispensing fee at the grocery store Kroger pharmacy. Again, all these numbers are fictional. They're just for illustrative purposes only, okay? That means that the new maximum allowable cost, in other words, the new amount that the PBM is going to pay the pharmacy, is the $8 acquisition cost plus the $12 dispensing fee, or $20. at A. Now, at B, it's going to be the $10 acquisition cost plus the $4 dispensing fee, or $14. And at pharmacy C, it's going to be the $12 acquisition cost plus the $4 dispensing fee, or $16. Now, note, in this new world, the plan cost, the copay amount, and the employer cost may not change at all. So that's why I left it at 50, 30, and 20, right? 50, 30, and 20, 50, 30, and 20, 50, 30, and 20. So that can like not change, right? 50, 30, and 20, 50, 30, and 20, 50, 30, and 20. So for all you employers out there, I would argue that it would be helpful for you to sit down and go through a specific example for a specific drug that goes through every single one of these fields and say, hey, Mr. or Mrs. PBM, what are you willing to actually tell me are the numbers to fill in here, okay? Because that's going to give you your actual answer for how this is going to affect your plan. Okay, so again, for simplicity's sake, let's just say the plan is still paying 50, the copay is still at 30, and so then what the plan sponsor is going to be paying, what the employer is going to be paying is going to be 20. Okay, now let's take a look at the pharmacy spread and the PBM spread in this new world. Okay, so now look at this. The pharmacy spread is now only $12, where it used to be $32, and because the pharmacy spread is just the dispensing fee, right? 12 and 12. Now, same thing here at pharmacy B. The dispensing fee is 4, therefore the pharmacy spread is 4. Again, at pharmacy C, the dispensing fee is 4, and therefore the pharmacy spread is 4. Now let's look at the PBM spread. So now the PBM spread is 30, right? It's going to be the plan payment of 50 minus the 20 at pharmacy A. It's going to be 36 at pharmacy B, so it's going to be the plan payment of 50 minus the 14. And at pharmacy C, it's going to be 34. It's going to be the plan payment of 50 minus 16, which gives you 34. Again, if you run the math on it, if you add up the pharmacy spread and the PBM spread pricing here, the 12 plus the 4 plus the 4 plus the 30 plus the 36 plus the 34, again, that adds up to 120. So the amount that the middlemen have taken hasn't changed at all, okay? In this new world of CostVantage, what the middlemen are taking hasn't changed at all in total. However, you will notice that I have these area boxed in, okay? That is what CVS controls, right? CVS controls their Caremark pharmacy. They control their CVS Pharmacies, because we're saying pharmacy A is CVS. They still control the PBM at pharmacy B, and they still control the PBM at pharmacy C in this example. Okay, that means that what CVS is capturing is what they have at their own pharmacy plus their PBM at each of the 3 locations. So what CVS in the old world is capturing is 32 plus 10 plus 42 plus 27, which adds up to 111, whereas the outside pharmacies, in other words, what CVS is not making as middlemen, they're getting $9, right? And the 9 plus the 111 equals the 120. Now let's go to the new world. Let's go to the CostVantage world, okay? In the CostVantage world, CVS is getting $12 at their own pharmacy, plus $30 from Caremark at their own CVS pharmacies, plus 36 for pharmacy B, plus 34 for pharmacy C. If you add up this 12 plus the 30 plus the 36 plus the 34, that adds up to 112. So look, it's only $1 more, whereas the outside pharmacies are getting $8 instead of 9. So not much has changed. That's my point. CVS is getting $1 more, which, oh, by the way, when this was announced, CVS's stock went up that day and the next day and the next day, which is unusual for CVS stock because CVS stock has been going down and down and down for months. CVS has been under pressure from the pharmaceutical industry, from Congress, from Mark Cuban's cost drug program, from transparent PBMs like Capital RX and Med1 and other ones. Okay, so CVS didn't want to change. They basically, through a variety of outside forces, were sort of forced to change. However, this change to a dispensing fee results in very little change in terms of how much they take home. Now, what does this specifically mean for things like the Mark Cuban Cost Plus drug program? Okay, so let's just say for this particular drug that Mark Cuban gets it for $20 for a 30-day supply. This is where historically, if you had let's say like a consumer-directed health plan where your actual cost was pretty close to the MAC plus a little bit more. Look, you can see that the cost at the pharmacy was $4.0823. So if you use Mark Cuban's cost plus program, then you would be much better off at pharmacy A at CVS to not fill it at CVS and to fill it at Mark Cuban. Okay, likewise, you'd be better off at pharmacy C to fill it at Mark Cuban. But look at pharmacy B, it'd be better to fill it off there than at Mark Cuban. Okay, now, note in this new world, the MAC is now 20, 14, and 16. In other words, even at CVS, the most expensive MAC out there, it is comparable to Mark Cuban, and the other two places are less. Why is that? Because more money was shifted away from the pharmacy, right? The pharmacy is only getting $20, and more money is staying with the PBM, right? The PBM spread in this situation went from 10 to 30. So, and oh, by the way, the same thing applies to GoodRx. Let's say the GoodRx amount, instead of being 20, was 23. The math is the exact same, which is why when this was announced, GoodRx's stock price went down, because this change is not good for Mark Cuban or for GoodRx. Now, so what they've done is they basically changed where the dollars go from the pharmacy to more towards the PBM, whereas the total amount that actually CVS gets in its combined pharmacy and PBM is almost the same. So, as an employer, as a plan sponsor, as a broker, as a consultant, what I would say to you is that if you want to find out specifically how these changes in CostVantage and TrueCost relate to your plan, my suggestion is, I made up these numbers as an illustration, is to go to your PBM, to go to CVS and say, hey, let's fill in pharmacy A, B, and C. Let's fill in the acquisition cost, the MAC, the plan cost, the copay, the employer cost, the pharmacy spread, and the PBM spread in today's world versus the future state of CostVantage. Okay, and then let's go through the exercise of filling in all these boxes. And I think if you sit down with your CVS representative and fill in these boxes together, you'll get a better understanding of how it's truly going to impact your plan and your plan members. And that's my point for today. Thank you for watching AHealthcareZ.